Dobrý den. Thank you again, Dr. Nevzorova, and to the organizers for inviting me. It's an honor to be here at your 4th annual meeting. Again, I think I need to start with an apology because I think the previous presentation is much more scientific and specific than the presentation I had planned. My plan was to just give a very basic discussion of the neurobiology of pain, and I think you've already had a better one in the previous hour. After discussion with Dr. Nevzorova, I will give the same presentation, but I'll try to introduce some clinical situations to illustrate my point. And also, if there are questions or comments, please feel free during the next 40 minutes, and perhaps our professor of neurology can answer some better than me, because I'm not a specialist in neurology. I'm not a neurobiologist. I'm just a humble palliative care doctor. Our professor of neurology, I'm sure, could provide answers for more complicated scientific questions. Okay, so I apologize, I missed the beginning of the previous presentation. I suspect you already heard about the basic neuroanatomy and neurochemistry of pain. So I'll just review very quickly and mention some of the concepts that were mentioned and present some clinical situations. So I think you heard about neuroplasticity, the ability of the nervous system to change, sometimes permanently. And this can lead to pain that is very difficult to treat. And as the neurobiologists are telling us now, pain is not just a symptom. Pain can become a disease in itself because of lesions in the central nervous system, particularly at the level of the dorsal horn of the spinal cord or the thalamus or in the cortex. So pain is necessary for survival, but it can also be, so that means it's physiologic and protective, but it can also be pathological. And as we heard in the last hour, treatment of pain is best if it is based on the differential diagnosis of pain and of an understanding of the mechanism. And I think the next decades, the next 10 or 20 years will be very exciting in neurology and neurobiology because, well, we're using the same medicine, opioids, that have been used for millennia with many side effects on the GI system, for example, as we heard. Can cause sedation, can cause constipation, delirium sometimes. So when as we get better understanding of the neurobiology, the neurochemistry, neuroanatomy of pain, hopefully there will also be cleaner medicines which block the pain stimulus without the side effects. So again, I think you've had these concepts explained. According to the International Association for Study of Pain, pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. There's not always clear tissue damage, and certainly there's not always obvious tissue damage. And it's also a complex experience that involves not only sensation, but also psychological and cognitive components or responses to the sensation. Right? Pain can have very different meanings. The pelvic pain, perhaps severe, of childbirth has a very, the birth of a very much wanted child has a very different meaning than the pain of cervical cancer, mediated by similar or the same nerves and of the same intensity. So the psychological and cognitive response is an important part of pain. So was there a diagram like this in the last hour? Yes? Yes, okay. There are just a couple of comments that I'll make, so to try not to be too redundant. The first order sensory neuron is what constitutes the peripheral nervous system. And then the central nervous system includes the second order sensory neuron, which has its cell body in the dorsal horn of the spinal cord, crosses the midline, and ascends to the thalamus, where it synapses with the third order sensory neuron, which proceeds from thalamus to sensory cortex. And one of the key locations involved in pain syndromes is this synapse of the first and second order sensory neurons in the dorsal horn of the spinal cord. And this is where neuroplasticity manifests itself. There can be changes, neurochemical and neurobiological, neuroanatomical changes, which result in a lowered firing threshold of the second order neuron, sensory neuron. And the same can occur in the thalamus, in specific nuclei of the thalamus. I also want to point out the descending pathway that proceeds from the hippocampus to the dorsal horn of the spinal cord. And I think this is an area of very intense research. And please correct me if I'm wrong. My knowledge is the limited knowledge of a clinician, not a scientist. But in this descending pathway, the endogenous morphine-like substances or endorphins are involved. This is why our bodies respond to morphine, because we make in our own brains a molecule that's very similar to the one made by these beautiful red flowers called poppies. That's why morphine is effective. Now, a clinical scenario. A soldier in war who receives a very severe traumatic injury, like a traumatic amputation of an arm, who doesn't feel any pain. Well, how can he not feel any pain? There's been severe injury to soft tissue. Bone has been broken and nerves have been torn, but yet there's no pain. Maybe not for a few minutes, maybe even not for an hour or two. And this is a well-described phenomenon, that patients, when they get a severe traumatic injury, sometimes they don't feel it. How is that possible? Well, Maybe in 20 years we'll know for sure, but the theory, and again, correct me if I'm wrong, is that there is an intense activation of the descending pathway such that the incoming action potentials from the damaged nerves and the damaged tissue are blocked at the level of the dorsal horn of the spinal cord. They cannot proceed beyond because there's been border police who are at the border of the central nervous system, and they don't allow the stimuli to enter, at least for some time, because of this activation of the descending pathway. So there's a lot of interest in figuring out how to activate that descending pathway and block the stimuli at the level of the dorsal horn, and find a medication that can do that without causing a lot of side effects. Neuropathic pain can be caused by injury to any nerve, right? We distinguish between nociceptive pain caused by stimulation of normal first-order sensory neurons, stimulation of pain receptors of one kind or another, and then transmission of an action potential with sequential opening of sodium channels that was described along normal nerves. Neuropathic pain is caused by injury to nerve, anywhere in the nervous system, peripheral or central. So when the surgeon performs an amputation of a leg or a breast, a mastectomy, that can result in neuropathy because nerves have been cut. When tumor compresses or invades a nerve, when there's a spinal metastasis and it's compressing a spinal nerve root in the L4, L5, S1 region, for example, and then there's sciatica. That injures nerves. What else can injure nerves? Well, infection. What about infection from varicella zoster virus causing shingles, or HIV itself, or doctors? We injure nerves with our toxic chemicals, whether it's isoniazid for tuberculosis, or parataxol for cancer, or stavudine for HIV. We use a lot of neurotoxic medicines that can cause neuropathy. And what about diabetic neuropathy? Well, probably caused by ischemia. The injury to the microvasculature that supplies blood to sensory neurons causes ischemia, and the nerves that are most damaged by this are the biggest ones, the biggest nerves that go all the way from L4, L5, S1 region to the foot, have the highest metabolic demands and the greatest surface area. So when blood supply is inhibited because of microvascular disease, there's ischemia and neuropathy develops first in the feet, whether it's from a metabolic cause like diabetes, or from a neurotoxic medicine like paclitaxel. It's usually first in the longest nerves with the biggest metabolic demand, so the feet and the hands. So I won't go through all these terms because I think you've already heard them. the transduction that occurs in the periphery with, which generates nociceptive pain. There can be stimulation of many kinds of receptors, from touch or pinprick or pressure. I'll call attention to the one with the fire and the hot peppers. So it's been demonstrated that the same molecule, the same receptor that mediates heat perception also mediates the sensation of hot peppers. That's why it feels like burning sensation. It's the same receptor. Next time you're having a spicy meal, you can remember that. I won't go into that kind of detail. So this cartoon depicts the synapse between the first and the second order neurons and the neurochemicals that are involved. And this is where there can be a lesion. There can be a change in the configuration of the receptors on the second order neuron, downregulation, upregulation, a change in the receptors to create a lower firing threshold of the second order sensory neuron. And this can become permanent. This is what would be called central sensitization. And once that happens, the treatment of pain becomes much more difficult. When the second or third order neurons are hypersensitive, lowered firing threshold, then the treatment becomes difficult. Okay, so let me tell you about a case that a patient I was called to see recently because he had abdominal pain, and there was a concern, there was a right upper quadrant pain, and there was concern. This was a patient with some kind of cancer, I don't remember, maybe colon cancer, and came in with severe abdominal pain, and there was suspecting that he probably had liver metastases that were rapidly growing with liver capsule stretch. CT scan didn't show any liver metastases. In fact, there was no clear reason for this patient to have right upper quadrant pain, but the patient was complaining of severe right upper quadrant pain. So I went to see the patient, and as usual in palliative care, when examining a patient, I try to minimize the discomfort, and I make my exam focused. The textbooks always say, complete physical exam, complete mental status exam. Well, in patients who are in severe pain and can only speak for a few minutes and are quite confused, you're not going to be able to do a full physical and mental status exam, at least not and maximize the comfort of the patient. So I try to make the exam as short as possible and focused as possible, not leave out any part that's crucial, but not do anything that's not necessary. So I gently examined the back, I pressed a bit along the spine, and there was some sensitivity in the lower back. And then I did the exam that was just described in the last hour. I gradually, just very lightly touched the skin before pressing on, before doing a surgical abdominal exam and pressing so hard I could feel the mattress. I just lightly touched the skin. And when I came to the right upper quadrant, just very light touch caused pain. Well, this wasn't because of abdominal pathology. It was because of spinal pathology. His metastasis wasn't in his liver, it was in his spine. And it was pressing, spinal metastasis was pressing on a nerve root, and he had neuropathic pain in the dermatome that included the right upper quadrant. So my colleagues were fishing, as we would say in English. They were fishing for abdominal pathology, but there wasn't abdominal pathology, it was neuropathic pain. So be aware of how you can be fooled by the location of the pain. And then on further questioning, the patient reported that there was spontaneous pain, that he would just be lying in bed and suddenly there would be a severe, like an electric shock. I mean, he described classic neuropathic pain, but this wasn't, the oncologists and emergency physicians who evaluated him didn't appreciate that kind of explanation. Oops. So at least in my hospital, most doctors don't know what allodynia is or hyperalgesia. And I'm constantly having to teach not only the young doctors and medical students, but also my senior colleagues, in a very respectful way, of course. These are not familiar concepts for most of my colleagues. So I think you've already heard about peripheral sensitization, but here maybe I should also mention inflammatory pain. Did we talk about inflammatory pain? Okay, so inflammatory pain is similar in a way to neuropathic pain, although caused by a different mechanism. So with inflammation, some of the neurochemicals that are dumped by the responding immune cells, the cells that, the white cells that respond to an injury or any cause of inflammation, can also sensitize the nerves in the area. So there's a sort of lowering of the firing threshold caused by inflammatory mediators. And so, although I wouldn't say that inflammatory pain is pathologic like neuropathic pain, the mechanism is somewhat similar in that there's a lowering of the firing threshold. I saw that you discussed wind-up, so that the sensation when I touched that patient in his right upper quadrant, the first touch was painful, the fifth and the sixth was even more painful. So I decided not to do a seventh and an eighth touch. There's the increasing sensitivity with further stimulation. So these next slides describe key differences between different kinds of pain. So three different kinds of pain. I think that, again, the distinctions we make between nociceptive pain, inflammatory pain, neuropathic pain, I think are quite primitive distinctions based on our primitive understanding of the central nervous system. All pain is mediated by nerves, so in a sense, all pain is neuropathic. But for therapeutic reasons, we distinguish between different kinds. Neuropathic pain is less likely to be fully responsive to opioid. Opioid is probably still the best treatment for moderate or severe neuropathic pain, but neuropathic pain is less likely to be fully or adequately treated by opioid alone than nociceptive pain. So nociceptive pain requires a noxious stimulus. The lesion, there's usually a lesion, it comes from soft tissue or bone, and you can either see the lesion with your eyes, or it's visible on the patient's body, or you see it with a scanner. You can see the lesion in the bone or in the liver. And it's protective, mediated by A delta and C fibers. Inflammatory pain also results from some kind of tissue injury with inflammation. But, as I mentioned, it mimics neuropathic pain, so there can be allodynia or hyperalgesia. or spontaneous pain. Lowers the firing threshold of the involved nerves. But it's a protective system. It's not purely pathological. And then neuropathic pain, where there's an injury somewhere in the peripheral or central nervous system, whether it's from infection or ischemia or transection of a nerve from an injury or from surgery, or compression of a nerve or infiltration of a nerve by tumor, or toxicity caused by medication. Was complex regional pain syndrome mentioned in the last hour? Okay. So again, difficult to treat. This was formerly called reflex sympathetic dystrophy, and even a minor injury can result in this, causing a marked sensitization of pain to pain in one region. It often involves one limb, and there's often a sympathetic component. So there might be a swollen red limb that's extremely sensitive. And again, this is very difficult to treat. So a diagram, I think this is fairly similar to what you saw in the previous hour, showing the medications that we typically use and the targets of those medications. So you see opioids have their effect both in the central nervous system and in the peripheral nervous system. Anticonvulsants, and again, amitriptyline is the most common, which may also have its effect centrally and peripherally. And are there available the serotonin and norepinephrine reuptake inhibitors? Duloxetine is the one that we use. It's beneficial in that it has less severe side effects, especially for elderly patients. Amitriptyline, which has a lot of anticholinergic side effects, is better avoided in frail elderly. It can cause orthostatic hypotension, tachycardia, which can be dangerous in patients who already maybe have a tachyarrhythmia or atrial fibrillation, delirium, constipation. So if you have a patient who's already constipated from opioid, then adding tricyclic antidepressant like amitriptyline can make the constipation worse. So in those situations, duloxetine might be preferable for treating neuropathic pain. But I always worry about what I see so much in the developing, especially in lower income countries. And I'm not sure this is an issue in Russian Federation, but pharmaceutical companies like to sell their very expensive medicines, and patients end up selling their possessions, borrowing money, going into deep debt, and becoming financially ruined to buy expensive medicines when inexpensive medicines are just as effective. So that's why the World Health Organization insists on oral immediate release morphine as the first line that should be available before expensive sustained release products, and why amitriptyline, if there's no contraindication, can be used for treating a suspected neuropathic pain before expensive preparations. Gabapentin and pregabalin were mentioned. My understanding is that pregabalin was created by a drug company because the patent on gabapentin was expiring, so they needed to have another expensive medicine to sell. So my perspective is, don't enrich the drug companies, which are already rich, anymore at the expense of patients. Just my personal opinion. Let's see. This morning we discussed also intrathecal therapy. Was that discussed at all? You discussed intrathecal? Oh, you did. Okay, good. I was reminded by seeing the mention of lidocaine, so local anesthetics can also be used in combination with opioid intrathecally. Those are all the slides that I prepared. And again, I apologize. I didn't know there was going to be such a wonderful lecture just preceding mine. Yesterday, during the discussion of the patient with diabetic foot and with the foot ulcer, I was thinking about the pain syndrome. And it's not predictable. A patient with diabetes and foot ulcers might have very severe neuropathy or might not. So it varies from patient to patient. And also, I think that many cancer patients have mixed nociceptive and neuropathic pain. So it's not, many patients, perhaps most patients, don't have just nociceptive pain or just neuropathic pain, but mixed. So anybody, for example, with a large head and neck tumor, there's so much innervation in the face that if there's a large tumor there, there's probably injury to nerve. So often you're dealing with a mixed syndrome. So I would say, to use the terminology of neurobiology, have a low threshold to treat for neuropathy with the medicines that were mentioned, gabapentin, amitriptyline, maybe duloxetine, if you suspect that there's a mixed nociceptive and neuropathic pain. So I can stop there. Are there questions or comments for either of the last two lectures? Because I saw there wasn't time for comment or questions from the last lecture either.
По предыдущей лекции, если были вопросы, коллеги, вы хотели задать? Вчера хотели, уже сегодня не хотите.
I guess I might just add two comments that occur to me as I'm anxiously waiting for your questions. For patients with refractory pain, we sometimes use either systemic lidocaine or intravenous lidocaine or intravenous ketamine. Lidocaine, as you know, is a sodium channel blocker, and based on what we know about action potentials and their perpetuation by a sequential opening of sodium channels, it makes sense that lidocaine might have an effect with any kind of pain. There's been some studies of intravenous lidocaine at the same doses that we used to use for treating ventricular tachycardia during cardiac arrest. And it's been found that bolus doses, which I believe, if memory serves, are 1 or 1.5 milligrams per kilogram, I believe, that sometimes a bolus dose can result within less than an hour, in 30 minutes, in excellent pain relief, even for pain that's been refractory to very high-dose opioid. And sometimes that pain relief can persist for days or even weeks. So the largest study that I know of from a hospice in the US was a case series of patients who had sustained pain relief from just a bolus dose of lidocaine. Sometimes, if the bolus dose is effective, I also start a continuous infusion. And this is partly related to the prognosis of the patient. If the patient has good pain relief but is near death and will probably remain in the hospital, there's little reason not to continue an infusion. If the patient will go home, then it's possible to see how long the pain relief lasts, and if it recurs, do another bolus. There have been attempts to then switch to an oral medicine that is similar to lidocaine, which is mixilotine. But mixilotine is so toxic, it causes nausea so frequently that it's not, people can't tolerate it. Ketamine also can sometimes be effective, and the doses I have to look up, I don't remember them, but again, this can be given intermittently, and sometimes with pain that's very refractory to opioid and even to adjuvants like gabapentin. Sometimes there can be good relief with ketamine. Ketamine is also used for procedural pain. So for example, our burn patients who have to have debridement of the burns, we often, or other painful procedures, even dressing changes for large wounds, if the dressing change is going to be very painful, we pre-medicate with a short-acting opioid like fentanyl and sometimes combine also with ketamine. And there can be good pain relief without a lot of sedation. Ketamine is sometimes is less sedating than higher dose opioid. Comments, questions?
Вер, помогите нам, пожалуйста. Вер, подойдите тогда. Уважаемые коллеги, я сейчас хочу спросить у Эрика про опыт использования кетамина в паллиативной помощи, потому что кетамин у нас есть. В стационарных условиях мы можем использовать. Единственное, что ни в паллиативных отделениях, ни в хосписах никогда мы этого не делали. Но препарат, зарегистрированный в больницах, в которых даже открыты паллиативные отделения, они есть. Возможность получить их в стационарной организации есть. И мы стали использовать кетамин в Первом московском хосписе. У нас прошло ни много, ни мало, но всего 3 клинических случая. Но для тех пациентов, которые были с выраженной рефрактерной болью, когда поднимались дозы опиоидных анальгетиков, мы не могли подобрать дозировки. В течение 1-2 суток боль была оккупирована, но буквально в следующую ночь мы приходили, и дежурный доктор делал неимоверные комбинации из других препаратов, и пациент не спал всю ночь. И вот эти прорывы боли и невозможность подобрать схему пролонгированными препаратами. И мы с Гузель Рафаэловной общались с одним из экспертов французских, который использует кетамин в паллиативной помощи, и мы заказали себе кетамин. Это оказалось совсем несложно, нам его привезли, около 20 ампул у нас было, и мы долго ждали, когда вот будет вот такой вот случай, чтобы использовать. И мы стали делать подкожную инфузию, четверть ампулы, там, по-моему, 25 миллиграмм, четверть ампулы заправляли на сутки в инфузомат, и в течение длительного времени, длительная инфузия, суточная, привела к тому, что мы пациентку молодую смогли уменьшить дозы опиоидных анальгетиков и купировать боль. Если у нас до приема кетамина пациент получал 300 микрограмм фентанила накожного пластыря и по 302 раза морфина МСТ, морфина сульфата в таблетках, и плюс еще кололась и морфин короткого действия, и антидепрессанты, и, в общем, что мы только не делали, и подбор схемы не получалось у нас сделать. И на фоне кетамина эта пациентка стала получать у нас 60 по 60 морфина сульфата в сутки 2 раза в день, то есть 120 миллиграмм в сутки. Мы совершенно ушли от фентаниловского пластыря, и умирала она у нас на продленной, в силу того, что перестала глотать, на инфузии морфина, также инфузомате, и кетамин. То есть у нас было 2 инфузомата, Сейчас мы с Ариф Ниязовичем на последнем клиническом случае сделали это в один шприц, то есть это было в одном инфузомате, и таким образом вот сняли эту острую боль рефрактерную и смогли с ней работать. И вот мне бы хотелось спросить у Эрика, насколько это используется и в его практике вот при таких состояниях, используется ли пролонгированный кетамин. У нас нет его в таблетках. И Московский эндокринный завод к 2025 году вот берет обязательство даже в таблетках кетамин нам в практику ввести. Но вот сейчас есть только ампульный кетамин, и вот мне бы хотелось услышать мнение Эрика, насколько он его использует часто.
Okay. Thank you. You know, I always carry with me in the hospital a little notebook with my notes in it, including doses of ketamine, and I didn't bring it with me because I wasn't going to the hospital. So I may not get the doses right. I might not remember the doses correctly. But the anesthesia, one of my colleagues who's also a member of the anesthesia pain service as well as the palliative care department did a recent thorough review of ketamine. And based on that, we developed some protocols. So one of the techniques that I've used sometimes is to give test doses of intravenous ketamine to see if it may be effective. Now, this has never been studied systematically, but the idea is if you give test doses of ketamine intravenously and there's good pain relief, then you can switch to oral, and you still have to find the right dose. There's no easy conversion from intravenous to oral ketamine like there is with opioids, because the bioavailability of ketamine, oral ketamine, is very low, and you can't predict how bioavailable it will be in a given patient. But if the intravenous works, then theoretically the oral should work at some dose. So what I do is explain it to the patient, and a common side effect of ketamine, as I recall, is excessive secretions. So we sometimes premedicate with, we use glycopyrrolate, but another one would be hyoscine. Do you have hyoscine butyl bromide or glycopyrrolate?
Yeah. Он у нас тоже только таблетированные формы, да, и инъекционных форм тоже, к сожалению, нет, только таблетированные. Но обещают нам.
That's fine. Yeah. So it can be uncomfortable, the excessive secretion. So premedicate with that. And then I give a dose. I think I usually start with either 2.5 or 5. I think I start with 2.5 milligrams of IV, and I'm not sure of the dose. And I wait about 15 or 30 minutes, and if there's no pain relief but no serious side effect, I double the dose. And again, same thing. If there's no pain relief and no serious side effect, I double it again. And I might go up to 15 or 20. And it seems that if a dose of about 20, a bolus dose of 20 milligrams in combination with the previous doses, so altogether maybe 30 or 40, if that hasn't brought any pain relief, then it probably won't work. If it did at any dose provide relief, then you know it might be effective. Of course, you can continue to give it IV, but if the patient's going to go home, then you can start an oral dose. And I think we usually start at about 5 milligrams 3 times a day, and then we go to 10 3 times a day or every 8 hours, and then 15. And sometimes it seems to be very effective, and sometimes it seems to be not effective at all, and I can't explain why. And the dose, it's limited by side effect, so I don't know, again, I'm sorry, I don't remember if there's a ceiling dose or what dose should not be exceeded, but we're using it actually more and more. Now, it's a very common drug in pediatric anesthesia, so I suspect that you use it commonly at Herzen for For anesthesia for children? Yeah. So it's available intravenously. Also, that reminds me of something that was mentioned in the last hour. It was mentioned that naloxone, which may only be available intravenously, is it available only intravenously except in that combination? Yeah. So now in the US we have oral versions of that, but they're extremely expensive. But it was mentioned that naloxone is not well absorbed from an intact GI tract. If there's a lesion in the GI tract, you can't be too sure. But if the GI tract is intact, it's not absorbed. So a palliative care trick that I used for years before we got an oral version of naloxone, you can give the intravenous naloxone, you can give it orally. And for very severe constipation, if you've been giving a stimulant laxative like bisacodyl and still it's not treating the constipation, you can give the intravenous, you can open the vial and give the intravenous liquid orally, starting with about 1 milligram, and you can give it also every 8 hours, and if that doesn't work, then go to 2 milligrams. And usually 2 milligrams is all it takes to get everything moving again, sometimes very quickly. And what I usually find with severe constipation like that is once the bowels are moving, once they've had 2 or 3 big bowel movements, you don't need to continue the oral naloxone. It can just continue the stimulant laxative. The one thing I would caution you is to be, if you order that, be very clear to the nurse that you intended to say that it should be given orally, because nurses might think, oh, this doctor made a mistake. Naloxone we don't give orally, we give intravenously. So then they give it intravenously, and then the patient is having a pain crisis. And that's happened. So write 6 times and tell the nurse 8 times, yes, it's not a mistake, I want you to give it orally. And they'll think you're crazy, but just say, do it anyway, and you'll make your patients very happy. Yeah, so intravenous lidocaine, again at the same doses that we use for cardiac arrest, ketamine, oral naloxone. Some tricks. Question or other question or comment, or for Professor? Yeah.
Если я правильно понял обоих лекторов, то патогенетически обосновано назначение одновременно амитриптилина, прегабалина, карбамазепина на фоне каких-то наркотических анальгетиков. Используются ли такие комбинации у коллег в Америке?
Лекарства повторите еще раз.
Прегабалин, например, карбамазепин, амитриптилин на фоне, скажем, морфина. Да, используют. И самое главное, используют ли нет подобной комбинации, скажем, у пациентов старше 70 лет.
Okay. Yeah. So, as a rule, if there's neuropathic pain that's not adequately treated by opioid, or if there's neurotoxicity or side effects from opioid, and I start one of the adjuvant medicines for neuropathic pain, I usually will just pick one, whether it's gabapentin or duloxetine or amitriptyline or carbamazepine, and increase it gradually until I either reach a maximum dose or there's toxicity, and if it's effective, then we have already the treatment we need. If it's not effective, usually, as a rule, I will stop that adjuvant medicine and start a different one. So I don't usually add additional ones. I try each one individually. Of course, this takes time, and meanwhile, the patient's in pain. However, you know, in a hospital like mine where all the most difficult cases are referred, we do ultimately sometimes combine medication. So we do have patients who will be on both gabapentin and duloxetine, and sometimes also ketamine. So in those situations, I always have to look up the drug interactions because I can't remember them all. So actually in my little pocket here, that's what I was just looking. I was looking up ketamine. I can look up the drug interactions because there can be, especially with, there's a lot of drug interactions with the antidepressants, with amitriptyline, with duloxetine, all the SSRIs. So be aware of drug interactions. If there's very severe refractory pain and the patient is near death, then my concern about possible side effects becomes less. So yes, occasionally we do have patients on multiple adjuvant medicines. Just like for very refractory depression, the psychiatrists will sometimes have patients on 2 or 3 different antidepressants. But that's the exception. Most patients, it's not necessary. Yeah.
Thank you.
Есть еще вопросы?
Спасибо вам большое. Эрик, спасибо вам большое, огромное.